the ultimate hope is cure for myeloma. And I think one of the things we're doing right now is we're waiting for people to have a huge tumor burden, to have a lot of biological changes and a lot of clonal evolution, a lot of changes in their immune system and organ damage. And then we tell them, oh, now I'm going to intervene. It's like telling someone, wait until you have metastases everywhere and then I treat you. So it doesn't make sense. Potentially we have the best drugs already available for myeloma, but we're just waiting way too long for us to use them and then we treat them. So what about trying to use those same drugs as early as possible, again with risk stratification so that we're not over or under treating, and asking the question, can we use it for a certain period of time, 1 or 2 years, where we can really treat, get them to a good remission and then leave them alone. And that's the beauty of it, that they are asymptomatic, they never had end organ damage and they stop therapy. But there are lots of questions. What are the time points that we have to use? What are the end points that we have to use in clinical trials? For how long should we treat them? Should we treat them until they have MRD negative disease or complete remission, so that we make sure that indeed we eliminate the clone and not have to keep them on maintenance for a long time? These are all great questions and we're studying those in clinical trials. We're also asking the questions of immunotherapy as early as possible. So we're bringing in bispecific antibodies, CAR T therapy early in smoldering myeloma, because we know that immunotherapy matters, and using it as early as possible when you have an intact or relatively intact immune system and less tumor burden is the right approach for those patients. So think about how amazing that will be very soon for us to see that our patients don't need their RVD len maintenance forever. They may actually benefit from just immunotherapy early on.